Good morning, everyone. Welcome to today's webinar. This is brought to you by the New Zealand Multiple Sclerosis Research Trust. My name is Amanda Rose. I'm the National Manager at Multiple Sclerosis New Zealand. Our two organisations work very closely together, so I'm very pleased to be able to share this webinar for them today. And I hope everyone's going safe and well in lockdown. Hopefully this is helping to keep you a bit busy. And thank you for getting up this morning to do this. Thank you also to our speaker, Dr. Jokubaitis, who is up very early before 8 o'clock this morning to present to us today. Just a little bit about the Research Trust. So the Research Trust is obviously focused around stimulating, coordinating and supporting New Zealand-based research, but it's also interested in disseminating research findings, which is why these webinars like today's one are so important. As we know, MS is increasingly becoming a condition that impacts young women and men, and the average age of diagnosis in New Zealand is in the mid-30s. So the question of fertility, family planning, health is very at the forefront of people's minds. And Villaha is probably one of the forefront leaders in research surrounding MS, pregnancy, and fertility. She's a senior research fellow at the Department of Neuroscience at the Central Clinical School at Monash University, which is based out of Melbourne. And she also leads an international women's health, pregnancy and neonatal outcomes registry. And that's integrated with MS Base, which Villaha will talk a little bit about later on. As a mother herself, she's driven by the passion to improve advice that women with MS and their neurologists have. So much of her research is focused around pregnancy and MS. Villaha will break after each topic and is happy to take questions. So you're able to type these into the chat function, then I can ask these of Villaha and she can address these. She won't directly in her talk be covering women's health unless that's changed, but is happy to take questions on this at the end of the session if you have any that you'd like to ask.
Thank you very much, Amanda. I am just going to share my screen. Hopefully this is going to work. I'm playing Zoom bingo with this.
Yep, that's good.
That's right.
Yep, it works.
Okay, thanks. Okay, so thanks, Amanda, for the invitation to speak to you all today. As Amanda said, I'm Villia and I'm a senior research fellow at Monash University. So I think before I really begin, I wanted to introduce MS Base to you all. And that's because it's a database which I use a lot for a lot of my research. And so a lot of the research findings that I'll be presenting to you today actually come from this database. I'm one of the scientific leadership group members for this registry, and I am the co-chair and scientific leader of our pregnancy, neonatal outcomes and women's health subcommittee. So this registry, I realised on this picture when I put it in the other day that it's a little bit embarrassing because I noticed that New Zealand is actually missing from this picture, so I apologise profusely. But basically the registry currently contains over 77,000 individuals around the world who have multiple sclerosis. And we collect all sorts of information about these people. And that information includes basic demographics, so somebody's gender, their date of birth, when their symptoms began. We measure disability, relapse information, which medications they're on, MRI information, and also pregnancy information. And when I checked our database the other day, I saw that there are actually 307 Kiwis enrolled in this database. The really nice thing about this is that all of the information that we collect is anonymised, so we have the ability to ask and answer lots of really important questions, whether they're epidemiological or to do with prognostics or to do with pregnancy, without identifying any individual. And it allows us to really, hopefully, provide some really good advice to people about the disease. I feel like Amanda's already gone over this, but it was interesting when I was having a look to see that there are about 4,000 Kiwis that have MS. I didn't sort of realise what the prevalence was. So it's not too dissimilar to what it is in Australia, actually. And I guess, you know, one of the key things that is really interesting with MS is that the female to male sex ratio when it comes to relapsing remitting MS is actually increasing, and it's been increasing over decades. So it currently sits at about 3 to 1, so 3 women to every man who's diagnosed with MS. And this is some data that we have from a number of different studies around the world. So this is a Canadian study, this is a study from MS Base and an Australian study. And what each of these show us is that over time, over the last decades, we've been seeing an increase in the number of women diagnosed with relapsing remitting MS as opposed to men. So that ratio has been increasing. And so really the question begs, why is this so? Why is it that more women are developing MS than men? And so the question is, could it be genetics? Could it be something to do with our sex chromosomes? And whilst there is some new evidence that suggests that there might be a genetic variation associated with the female X chromosome that's associated with MS risk, really we can say that it's unlikely to be a genetic cause because our genes just don't mutate that quickly in order to explain that sort of rapid rise in the number of women being diagnosed. So then there are a number of other health and lifestyle factors that might play into this. We know that, say, for example, childhood obesity is a risk factor for MS. And we know these days that with increasing sedentary lifestyles, that could be playing into it slightly. It's also been suggested that there's been an uptake in the increase of women who smoke. And we know that smoking is also, again, one of the potential risk factors associated with the development of MS. But the other thing that's been really linked to this possible change in the sex ratio is actually pregnancy. And so what we've found is that over the last decades, women are having fewer and fewer children and they're waiting a lot longer in order to become pregnant. And so it's been suggested that this might also play into this changing sex ratio, that there's something to do with sex hormones and pregnancy that might lead to protection against MS. And so we're actually quite interested in this in my group. And so we had a look at it. And so this is Elan Nguyen. She was one of my talented PhD students who just completed her PhD earlier this year. And what we asked and what she answered was whether or not pregnancy could actually have an impact on the age at diagnosis of a clinically isolated syndrome. So that's the first symptoms associated with MS. And so we surveyed over 3,500 women who have multiple sclerosis from around the world. And in this particular study, we're able to analyse just over 2,500 of those women. And we asked them really detailed questions about their pregnancy histories, including whether or not they'd had any miscarriages and terminations, as well as live births. And she broke down her analysis into any pregnancy, whether or not it was terminated early, as well as live births. And what she found was that women who had any pregnancy, so whether that was a termination or a miscarriage, any duration of pregnancy was actually protective against the onset of a clinically isolated syndrome, or it delayed the onset of a clinically isolated syndrome, as did a live birth. And what you see in these graphs is the age at which women with pregnancies and in the yellow line without pregnancies developed a clinically isolated syndrome. And so we found that pregnancy could actually delay the onset of a clinically isolated syndrome by about 3.3 years in the pregnant stage and about 3.4 years in women who had live births. So the effect was more or less the same. Okay, so that's a bit of an introduction as to why we're, particularly interested in MS and pregnancy. But I think, the other thing is, as Amanda highlighted, that more and more women are being diagnosed with MS at an age when they're potentially family planning. And I think that there's a lot of information that's missing out there for neurologists as well as in the community in terms of how best to manage women with MS through this journey. And also men. I think men are actually particularly understudied in this area. And so recently I was asked to be part of a group to put together some consensus statements on pregnancy and breastfeeding and how best to manage that. And so whilst I was originally going to talk about women's health in this talk as well, I thought maybe a good way to sort of approach this talk instead was to really go through the guidelines that we've developed and that are going to be published soon. Because we think that there's a lot of information that people in the community and also neurologists, but who aren't necessarily specialists in MS, don't necessarily know or aren't on top of. And so that, depending on where you're managed, if you have MS and who looks after you, maybe there'll be some pointers in here of things that you can potentially ask them as well if you're thinking about family planning. And so we've broken these down into 4 key areas. So we have some pointers on pre-pregnancy counselling, on prenatal advice, pregnancy and postpartum. And so, as Amanda said, I'll pause at some certain stages so that you can ask any questions in particular, but I thought I'd go through these guidelines. Okay, so to start with, looking at pre-pregnancy counselling and some of the advice that we have. Oh, sorry, my slides have stopped working. There we go. So with some of these guidelines, I think what I'll do is I'll just read through some of them, and with the others, I've decided to actually show you some of the scientific evidence behind why we're saying what we're saying. And so with respect to pre-pregnancy counselling, one of the key factors that we think is that all women of childbearing age should actually have pre-pregnancy counselling, ideally really early on in their diagnosis or at diagnosis, mostly because of the age at which women are typically diagnosed with MS. And we also believe that women should be advised that if they are considering pregnancy, that they should discuss this with their MS team before they decide to start to trying to conceive. And another thing here is that we believe, to the best of our knowledge, that MS does not actually affect fertility. And so that if you are trying to have a baby, and particularly if you're on any sort of disease modifying therapy, that you actually should be on contraception. So let's have a little bit of a look at the evidence in and around fertility. So this is still a little bit controversial. The general agreement, as I said, is that MS does not affect a woman's fertility. And this is evidence derived from a number of different studies. Most of them have been pretty small, actually, and they have looked at something called the anti-Müllerian hormone, or AMH. And so what AMH is it's a hormone that is associated with the level of ovarian reserve, or the number of eggs that a woman has left. As I'm sure you're all aware, women are born with a limited number of eggs, which is all that they have for their entire lifetimes. And so the anti-Müllerian hormone just really is a really good measure to work out how many eggs are or aren't left. And I guess one of the first studies to really look at the level of this hormone, and therefore ovarian reserve and fertility in women with MS, was a German study where they looked at the anti-Müllerian hormone in women aged between 18 to 35. And they looked at 73 women with MS and 58 women without MS. And they found that women with MS had a significantly lower level of this hormone, and therefore lower egg reserve, than those who did not have MS. And these women were a range of women. They were treated with a number of different disease-modifying therapies, as well as some were untreated. Some of those are listed there. So there was a bit of a question as to whether or not, it was potentially one of the therapies that they were on that was affecting these levels of AMH. But when they looked at the different therapies that the women were on, they found that the therapy itself had made no difference, that irrespective of treatment or lack of treatment in these women with MS, they all had, typically speaking, a lower level of AMH than women who did not have MS. Then there are two other studies that sort of counteract this. One is from the US, looking at women aged between 22 to 65, and there are almost 600 women in this study. And another is an Iranian study that was just published last year with much smaller numbers, but women aged between 18 and 45. And both of these studies actually found that there was no differences in the level of the anti-Müllerian hormone between women with MS and women without MS. So really the jury is still out as to why the German study found there to be a difference in the egg reserve. And so this is something that is an area of ongoing research, but as a general rule, we believe that there's probably no difference. Having said that though, this is a really neat study that was published again just last year from the Danish registry. And the really nice thing about all of the Scandinavian countries is that actually they're able to link a lot of their healthcare systems together. And so unlike in Australia, at least, our healthcare systems aren't integrated. So for example, if somebody goes for fertility treatment, that information is kept within the IVF clinic, but it's not linked to their general health records, whereas in the Scandinavian countries, all health records are linked. And so what these doctors and scientists were able to do was they were actually able to have a look at all of the births that were recorded within their population and compare the births of people with MS, or how many children they had, relative to the rest of the population. And so they were able to look at actually a really massive number of people. They actually ended up analysing just over 9,000 individuals with MS and almost 38,000 people without MS. And so they had a look at the number of live births that both men and women had before the diagnosis of MS. And so that's in this table over here. And what they found was that women who were destined to have MS but did not yet have MS at the time still had fewer live births on average than women who did not develop MS, whereas men had the same number of live births before their diagnosis. After the diagnosis of MS, however, they found that both men and women all reduced the number of children they had on average. And so that's sort of borne out in this graph here as well, that the number of children in general, or live births for women with MS, is not very high. But you can also see that the number of births for women have been increasing over time. And that's really due to a change in the advice that women are being given over the decades in terms of pregnancy and the impact of pregnancy on MS. Why is it, though, here that we found that women had fewer births than, women with MS had fewer births than those without MS? That could really be to do with this new concept that's just been around quite recently, actually, about the MS prodrome, that some women already go and see their doctors a bit more frequently before the onset of MS with non-specific symptoms. And so there's a question as to whether or not, in general, maybe they're not feeling quite as well in general before the diagnosis, and that might play into it. Why are they having fewer children after the diagnosis? Well, that's a little bit more complex. This is another study also looking at the same issue from the French registry. And again, they have national registries where they're able to look at combined data. And here they looked at the average number of children women with MS and women without MS had within their French registries. And in the blue columns, you can see women with MS, and in the orange columns, it's just the national French registries. And again, you can see that over the years and over different age brackets, women with MS, again, tended to have fewer children. And so the sort of reasoning behind this is multifactorial, I think. A lot of research suggests that it could just be to do with changing attitudes. Once you have a diagnosis of MS, you might change your mind about wanting to have a family. Some studies have shown that some people are concerned with respect to social issues, such as being able to remain in employment and therefore being able to afford to have children. Some are worried about what impact that might have on their disability and whether or not they think that they're going to be able to care for a child if they have a disability. Some people are worried about transmitting MS to their child because of genetic factors. And I can say that there's, whilst there is an increased chance of having a child who ends up developing MS if you yourself have MS, it's still very low. It's still, if somebody with MS has a child, their child only has about a 3% chance of developing MS as well. So super low compared to most other conditions, which I think is very reassuring. But then again, you know, there are other questions about why this might be happening. Again, going into maybe a decreased ovarian reserve, but also I think a topic that can seem quite taboo and uncomfortable to talk about is also sexual dysfunction. And the statistics around MS and sexual dysfunction are really all over the shop. And I think that is because people typically feel uncomfortable talking about it. So depending on which studies you read, people with MS do quite commonly suffer from sexual dysfunction. Depending on which study you listen to, it's anywhere between about 40 to 80% of people. And so that could be to do with either, for women, having dryness, for men failing to achieve an erection. It might also be to do with pain or spasticity, or quite frankly, fatigue as well. So there are a number of different factors playing into that as well. And I think that, you know, whilst it might feel uncomfortable talking about it, if, you know, it's something that affects you, you should certainly feel comfortable talking to your doctor about it as well. Okay, so the one other, I guess, key point that I wanted to talk about is that we're often, when we talk about these things, talking about female fertility. You know, I just did talk about sexual function and how that might affect men, but I think, you know, there's very little research done in terms of male fertility and multiple sclerosis. But there was this study done, again, by the Danes, because they're able to link all of their medical registries together. And what the Danish registry did was that they actually looked at all men whose partners underwent fertility treatment. And so you can see these numbers are absolutely huge. There were over 51,000 individuals who were part of this study. And they found that there were just over 24,000 of those men who had male factor infertility, which is why their partners were seeking treatment. And interestingly enough, they found that men who had male factor infertility had a higher risk of having MS. So it's not to say that the relationship necessarily goes both ways, but it sort of asks the question as to, again, whether or not there are any sort of autoimmune connections between the two, whether or not infertility and MS do share some common biological pathways. The final thing that I just wanted to quickly touch on in the context of fertility and MS was the topic of assisted reproductive technology. Now, some of you may have heard previously that if you undergo IVF, for example, that you have an increased risk of having a relapse afterwards. And so there was a meta-analysis, which is basically just a study where scientists pull together all of the different published literature and try to interpret it all together. And they looked at this topic to see whether or not there's anything in that at all. And so they looked at a number of different studies, 5 of which showed that, so the green bars are the average number of relapses that women had in the year prior to trying IVF. And the red bars here represent the number of relapses on average in the 3 months after IVF. And so you can see in these 5 studies that there was a large increase in the relapse rate in the 3 months after IVF. In 5 of the 6 studies, the 6th study did not find that effect. And when they analysed it all together, even though there was a lot of variability overall, it would suggest that there is an increase in relapse rate after trying IVF. And again, there are a number of different reasons as to why this might be the case. Typically speaking, if people are undergoing IVF, they might stop using a disease-modifying therapy for their MS. And when you withdraw therapy, there's an increased risk of having disease reactivation and having a relapse. I think, you know, the other things in and around that as well are that undergoing fertility treatment can also be a very stressful event. And we know that stress can also precipitate relapses. And so I think, again, it's multifactorial, and we're looking into this further. There's some new research that's going to be starting in Australia soon, and I know there's a lot of global efforts looking at this as well to try to work out whether or not this is specifically MS related, or whether or not there are other factors that play into it, such as stress, fatigue, and so forth. Okay. So I think I might just pause here, and if anybody has any questions, I'm happy to answer them at the moment before I keep going.
We have one question.
Yeah, okay.
I'm Gitika, so this is Seamus. Me and my partner are going through IVF treatment at the moment, so that was really, really useful. Thank you. I'm on Tysabri, and yeah, I was a little bit uncertain about going, you know, carrying on with the medication during the IVF process. So I've just had the embryo transfer, and just my infusions was due like as in yesterday. So my question basically is around, you know, with treatment, is it the disease modifying therapy type treatments like Tysabri, is it useful? Is it, sorry, what am I trying to say? Is, you know, the effects on pregnancy going forward, I guess, like say with the embryo transfer at the moment, waiting on that result. And then if that's positive, then obviously the next 9 months or so. I guess what I'm just trying to figure out is in terms of that therapy, is it safe for both me and the baby, I guess. I don't know if there's any, I have gone on Dr. Google and checked this out as well. There is a lot of research out there, but I just wondered, in terms of the therapies like Tysabri, just in terms of the embryo transfer part of IVF, and then, if you were to get pregnant, then, the impact on baby and mother.
Mm-hmm. Sure. So my big first qualifier is I'm not a neurologist. So I think, it's really important to talk to your neurologist about this. I think you're also in I don't want to say unique situation, but still a situation that we don't have a lot of research on, which is the impact of disease-modifying therapies and how they interact with IVF. I'm going to actually talk about Tysabri in pregnancy a little bit later, but I'm happy to sort of talk to that briefly now, which is just to say, and I'll go into it a bit further later, that of all of the disease-modifying therapies that are out there at the moment, Tysabri is actually one of the ones that seems to be most compatible with pregnancy. So a lot of doctors do feel quite comfortable using it. How that interacts, though, with embryo transfer, that's something that we really don't have much information on. There is some literature out there that suggests that it may impact implantation. But again, it's very, very sort of early day research. And so I don't want to hand on heart say either which way. So I think it's really important to talk to your neurologist about it. Thank you for that. I've actually deferred the infusion for another 2 weeks anyway. So I thought if I just had the transfer and then infusion, it was probably, probably safer to do that. That's the nice thing about Tysabri as well, in that, there's recent studies that have just come out as well, which show that having an infusion every 6 weeks is more or less as effective as having it every 6 weeks is more or less as effective as having it every 4 weeks. So I think it's kind of nice in that, you do have a little bit of leeway with it as well. Okay, so moving on then with some of the other consensus statements in and around pre-pregnancy counselling. So the next point that I really wanted to speak to was that, women with MS should be reassured that pregnancy doesn't increase the risk of disability worsening in MS. And so this is actually an area which I've done quite a lot of research in, and something that I've been particularly interested in. And so looking at the short-term effects of pregnancy on disability outcomes, we just published a paper this year, actually, by another one of my very clever PhD students. And what we looked at was, actually quite a lot of things, and I'll talk about this paper a fair bit, but one of the things that we looked at was the short-term effects of pregnancy on the accumulation of disability. And so what we mean there is that, neurologists often measure the amount of neurological disability that a person with MS has using this score called an EDSS score. And it's just basically a way for the neurologist to have an objective measure of how much disability somebody has. And so what we looked at was the amount of disability that women had before their pregnancy, before conception, and also up to a year after giving birth. And what we found in this study, where we looked at it was 1,600 women for about 2,000 pregnancies, we found that only about 5.6% of women had a significant increase in measurable neurological disability within the year after birth. And the most common predictor of who was going to accumulate disability over that time was whether or not women had a relapse either during their pregnancy or in the postpartum period. So in other words, disease activity in MS is associated with the increase of disability. And so that if women who are pregnant are having disease activity during their pregnancy, having relapses, then that's more likely to increase the amount of disability that they accumulate. Now, the really good news about our study, though, was that we found that it was about 5.6% of women. A paper published back in 2008 showed that it was 13% of women. So what this really tells us is that doctors are getting a lot better at managing women with MS through pregnancy in terms of the advice that they give them and how they manage them with various disease-modifying therapies. So the risk of accumulating disability over time is actually decreasing. Not that it was particularly high in the first place, but I think that, you know, in terms of the short-term effects, women can feel very reassured that having a baby is not going to significantly increase their chances of disability worsening. Ooh. My slides don't want to progress again. Okay, so what about the long-term effects? So again, this is a study that we published back in 2016. And in this study, we were really interested in identifying what sorts of things determine the amount of disability that a person accumulates with MS over a 10-year period. And we know that over a 10-year period, a lot of different things can happen in a person's life, including having children. And so we looked at, again, just over 1,800 women in the study who had relapsing remitting MS. And we wanted to see what effect having children had on the accumulation of disability. And what we actually found was that those women that had had babies accumulated less disability than those who had not had any babies. And we looked at this a little bit further just to see, you know, how did the effect of pregnancy, if it was protective against the accumulation of disability, how did that compare against injectable therapies? And interestingly enough, we found in our analysis that women who had children, the effect of pregnancy was about 4.5 times more potent than the effect of injectable therapy, so your interferon betas and your copaxones in preventing the accumulation of disability. So that really actually shocked me and surprised me, and was one of the reasons that really got me even more interested in looking at pregnancy and disability in the context of MS. Now, whilst we found that pregnancy has a protective effect against the accumulation of disability, there was another study published relatively recently that found that pregnancy had no impact whatsoever on the accumulation of disability. It didn't increase it, didn't decrease it, just completely neutral. The differences between our work is that we measured disability a little bit differently, which might sort of explain some of these things, but regardless, you can rest assured that in the long term, pregnancy certainly does not lead to any disability worsening. Now, I think, you know, we often, when we do these studies, we talk about women with relapsing remitting MS, and that's really because firstly, relapsing remitting MS is a lot more common than progressive MS. And also women with progressive MS, so whether that's primary progressive or secondary progressive, they don't tend to have babies quite as often. So we have less data to work with. But this is some work again from our MS-based registry that we presented a little while ago now, and something that we're actually working towards increasing our numbers on at the moment. But here we looked at what impact pregnancy had on women with progressive MS, which are, as I said, quite understudied. And so what this graph shows us, I quite like this diagram, is it shows us disability scores over time for 9 different women who had progressive MS and had a pregnancy. So this grey column down the middle is the time at which women were pregnant, and the sort of the end of it is the end of the pregnancy. And over across horizontally, we can see the disability scores of these women plotted as little dots along the way. So every single time that they had a disability measure, that disability was plotted. And it was based on EDSS scores, as I've mentioned. That's that sort of objective measure that neurologists use to work out how severe somebody's MS is, where a 0 score means that there's no appreciable disability. And it sort of works its way up to a score of 10. And so what you can see is that after a pregnancy, there really was no effect, even in women with progressive MS, of having a pregnancy and what their disability looked like. So you can see that, so for example, in this maroon graph, this woman with progressive MS had a pregnancy, and after pregnancy, her disability decreased slightly. The purple graph shows a woman whose disability kept on tracking the way that it was always tracking. Some stabilized, so really there was no appreciable difference. At the moment, we've been working on actually surveying a lot of women around the world. So I think at the moment, a new study that I'm leading, we've surveyed just over 5,000 women with MS about their pregnancy histories in order to identify more women with progressive MS who have had pregnancies. And so what we're hoping to actually be able to do is to be able to expand on this and to, again, get better advice and better knowledge on the impact of pregnancy on women with progressive MS. But at the moment, at least, we can say that, again, much like with relapsing remitting MS, if nothing else, it doesn't seem to make any impact on long-term disability outcomes, which again, I think is reassuring. Okay, so the next point in our expert consensus statement is that women with MS should be aware that relapse rates may reduce during pregnancy and increase in the 3 months postpartum. And that the relapse rate in the year after pregnancy should return to the same as that of a woman who's not pregnant. So what do we mean by that, and where do we get this evidence from? So as I said, when I was talking about fertility and I showed that Danish registry study, you could see that over the years, the number of women having pregnancies was slowly increasing. And that really is thanks to this paper that was published back in 1998 in France. And this was a really groundbreaking study at the time. Prior to this study, neurologists feared that pregnancy might actually worsen disability outcomes for women with MS. And so they were actually actively discouraged from having children. But in this study, they identified 227 pregnancies in women with MS. And what they did was they measured relapse rates for women over time. So this was in the year before pregnancy. This grey panel here is during pregnancy and then thereafter. And what these doctors were able to show was that looking pre-pregnancy, where relapse rates at the time were relatively stable, they look quite high in terms of these numbers. But you also have to remember that this was really before the introduction of disease-modifying therapies. And so you could see what happened once women became pregnant is that the rates of relapse decreased, and they were lowest in the 3rd trimester, just indicated over here. But after giving birth, the relapse rates increased. It's called what we call a postpartum relapse rebound, because the amount of relapse that was occurring was higher here in this 3-month postpartum period than it was before pregnancy. But you can see that it started to stabilize back down again. And so this finding here really gave doctors confidence that pregnancy was actually okay for women with MS. And in fact, they might do quite well whilst they were pregnant. And so this, as I said, was a seminal study and really found that pregnancy was okay. But the thing is, as I said, this is a historical study before the introduction of disease-modifying therapies. And so what we wanted to understand was whether or not this still holds true in a time where women with more active MS are now having pregnancies because there are disease-modifying therapies available in order to stabilise their disease. And so these are 2 different studies, both published, one last year, one this year. And in this first one here, again, this is from what we call a meta-analysis, so where we pull together a whole bunch of studies from a whole range of different places, and we sort of try to compare the results across all of those studies and come to some sort of conclusion. Excuse me. And the one here is actually, again, a study from MS Base done by an incredibly talented honours student that I had last year, who was an Indonesian medical student, Yui. And so both of these basically show exactly the same thing, and thankfully they're both colour-coded the same way. And so what we're looking at here is that the blue bars represent historical pregnancies. So here in the meta-analysis, pregnancies between 1994 and 2004. Here in our study, more recent study, those pregnancies before 2005. The red bars are sort of 2005 to 2009 or 2010. And then the green bars in both, again, are sort of after 2009 here or after 2011 in our one. But what they basically both show is that over time, MS is being better managed. So you can see here that the average relapse rate is decreasing over time with the use of effective medications. So you can see that as the decrease from the blue down to the green in both of these. You can again see that during pregnancy, relapse rates drop and are lowest in the 3rd trimester in both studies. And then again, you see this relapse rebound in both of these studies thereafter. So that's just to say that pregnancy for some women is actually a time where they feel fantastic with their MS, that there's a lot less disease activity, but we do see this re-emergence of disease activity afterwards. And again, you know, you can see that relapse rates are slightly higher in the 1st trimester than they are in the 3rd trimester. And that's because pregnancy is actually really fascinating from an immunological perspective, in that in the 1st trimester, your body actually is still a little bit inflammatory, and we need a little bit of inflammation in order for an embryo to implant properly and to form all of the blood vessels that it needs in order to grow and survive within the mother. But then again, we know that the embryo is partly foreign. It's not entirely the same as the mother's DNA. And so then the immune system has to, in a sense, sort of dampen down its pro-inflammatory effects and be more anti-inflammatory in order for the embryo to survive. And that's why we typically see this decrease in relapse activity down to the 3rd trimester. But then just as you're about to give birth, all of the different pregnancy hormones change again, and the inflammatory effects within the body also change again. And your body actually does have to go through a pro-inflammatory process again in order to prepare for childbirth. And so that's partly also potentially why we do see this increase in relapse activity after birth. Okay, so the final point here in terms of our consensus statements in terms of pre-pregnancy planning, and it's a lot to consider before you're even, you know, pregnant, is to do with the disease-modifying therapies. And so I'm quite guilty, I have to admit, in this talk of saying DMT. So DMT refers to disease-modifying therapy. And this really just is again to highlight that women shouldn't defer starting on a disease-modifying therapy if they've just been diagnosed and they're thinking about family planning, because we believe that it's really important to get a woman's MS under control and to be nicely stabilized before attempting pregnancy. And I'll go into it a little bit later, but some disease modifying therapies are okay to conceive on as well. But again, depending on which disease modifying therapy it is that somebody is taking, there are some that are okay to use and some that aren't okay to use. And so it's really important to have these conversations early on with your neurologist in order to decide which is the best drug to be on when thinking about family planning. Okay, so now moving on to prenatal advice. So we're sort of moving along the line here now. And with respect to prenatal advice, it's quite simple. You know, women with MS should be given exactly the same prenatal advice as women without MS, which is, you know, the same sorts of things. So healthy lifestyle, stop smoking. Women should be taking vitamin D supplements and folic acid in order, and just following normal standard obstetric advice. Again, looking at disease modifying therapies. So here we go. Women with MS who are currently on a disease modifying therapy should be having discussions with their neurologists about when to start or when to stop or whether to continue their DMT. And again, based on the individual safety profiles. Sorry. And so also, if women are planning to stop using their disease modifying therapy, again, you should be aware about how long it might take in order to conceive, in order to, I guess, try and ensure that disease reactivation doesn't become an issue as well. And so this is something that I was actually really naive about during my pregnancies as well, which is to say that all therapies, irrespective of whether they're MS related or unrelated, are given a pregnancy category rating. And these pregnancy category ratings go from an A to an X. And I've sort of listed what they all mean here. And so a category A medicine basically means that a large number of women have been on that disease-modifying therapy, on that medication, I should say, and have become pregnant on that medication, and there has been no increased frequency of malformations or any harmful effects to the fetus, so it's safe. So these are things like, say, paracetamol, for example, So things that have been taken forever and a day, and there's a lot of evidence around them. Then we have category B medicines. And these are medicines where there's not as much information about women who have been pregnant that have taken them. But with the studies where women have been using these medications and they have become pregnant, there's been no harmful effects reported in humans. And some of the safety data is often in these studies based on animal studies as well, because again, there's just not sufficient information in humans. And then it starts to go down the line where the lower the pregnancy category, so say a C or a D, it often means that there's either less evidence in humans or there's an evidence of increased risks or harmful effects to the fetus. So with the category C, it often is that there may be harmful effects associated with that particular medication to the fetus or the neonate, but it doesn't necessarily cause malformations, or without malformations, I should say, and often the effects are reversible. A category D medication means that it has caused or is suspected to cause, or it may cause fetal malformation. But that doesn't necessarily mean that they shouldn't be used, because we need to also consider the mother's health. And there's a lot of examples, for example, say with epilepsy medication where this is the case. And then we have category X medications, and these are ones that should absolutely not be used in pregnancy because there's really strong evidence to suggest that they do cause harm to the fetus. And so all of the MS disease-modifying therapies also have various category ratings. And so this is a really nice summary from Ruth Dobson, who is another leader in pregnancy research from the UK. And she put together a really neat sort of summary of all of the different disease-modifying therapies and how and when they should or shouldn't be used in the context of pregnancy. I've supplemented these with little category ratings. So in New Zealand, I believe your regulatory body is called MedSafe, and they use the same categories as we do in Australia, derived by the TGA. But different countries, so in America, the FDA have their own advice, and in Europe, the EMA have their advice. And so the advice varies a little bit between different regions. But here I've put the category ratings for Australia and New Zealand in terms of these medications. So Copaxone has a rating B, whereas the interferons have a rating D, and I'll sort of speak to that a little bit later. And you can see a variety of different category ratings, but one of the disease-modifying therapies that should absolutely not be used in the context of pregnancy is teriflunomide, also known as Aubagio. And that's because it has been shown to be associated with fetal harm. Although if you were to accidentally get pregnant on that, there are ways to try to accelerate the removal of that drug from the system, and then, follow healthcare advice from obstetricians and your neurologist as to what to do next. But this is a nice sort of overview, and we've also written a summary about these different medications and their safety profiles and evidence in a review paper in 2019. So there's a lot of information out there. I'll go into this a little bit more throughout the talk as well. But just a few things to consider before you're becoming pregnant, and things to discuss with your neurologist in terms of which medication you're on and whether or not it's safe to continue on that or whether you should switch. Okay, so the next thing that I wanted to talk about was about pregnancy in women with MS should not automatically be considered a high-risk pregnancy. And it shouldn't necessarily influence obstetric medicine. So for example, the delivery method, unless of course the person has significant spasticity, in which case this should be taken into account. And so this is really hot off the press. So I actually just finished looking at this data last night, and this relates to the information that we've been collecting from a lot of women around Australia and around the world. And here I've just summarised some results. This is unpublished. I literally just analysed it yesterday, looking at a survey of women that we've been doing here in Australia. So we've spoken to and surveyed almost 1,200 women in Australia. They've very generously been very honest and open about their pregnancies and pregnancy histories with us. And so here, of the women that we've surveyed, we've got 956 for whom we have over 2,000 pregnancies that have been recorded. And we ask them about all sorts of things in terms of pregnancy outcomes, delivery methods, reasons why they delivered in a particular way. And so here I've just summarised the outcomes for our women with MS who answered our surveys. And of the 2,000 plus pregnancies that we recorded, the really good news is, the nice news is that over 80% of them resulted in a live birth. And a couple of the women that we surveyed at the time were pregnant, which is really lovely. So we're looking forward to finding out about their pregnancies and their babies in the future. Now, we also found that we had a miscarriage rate in our particular survey of just over 11%, but actually the average, when you look at obstetric literature, average number of miscarriages, whatever, should be about 20%. So maybe it's a little bit underreported here. There were a number of abortions, and some of these were for DMT exposure reasons. We unfortunately did also record a couple of stillbirths and an ectopic pregnancy. But overarchingly, I should say, the vast majority of women with MS that we surveyed did end up with live births. So in terms of delivery, how they delivered their babies, so again, the vast majority had vaginal deliveries and unassisted as well. So only 17% of those for which we had delivery outcomes. Only 17% were vaginal assisted. And then about 25% were C-section. And when you look at the average Australian literature, they say about 1 in 3 babies is born by C-section. So this is actually really comparable, the MS population, to the general population. We've also had a look at the reasons as to why women delivered in the particular way. And this is, I think, particularly reassuring. So a lot of women didn't give a reason. I suppose, if you've got a vaginal birth, there's no reason really to give. But looking at the top reasons as to why women delivered the way that they did, the main reason why women had, say, for example, an assisted delivery or a C-section was because of standard things such as the presentation. So whether or not the baby was breech or posterior or transverse, so lying sideways. Other reasons for delivery methods was fetal distress, which is, not uncommon. Baby got stuck, women being diagnosed with preeclampsia or eclampsia. Medical reasons that were unassociated with their MS. Women having C-sections because they've had C-sections in the past. Failure to progress and so forth, narrow pelvis, large babies. And so when we looked at the answers that we received, very few actually gave MS as the reason for why they delivered in a particular way that they did. So here I've just put a note to myself. So 11 women reported delivering the way that they did because of their MS. But here I also added in long labour exhaustion, and couldn't feel contractions as additional reasons that may be MS related, related to fatigue and so forth. So again, having MS does not necessarily impact delivery methods or obstetric complications or anything like that, which again, I think is really reassuring. Okay, so getting back into the nitty-gritty of disease-modifying therapies. And so, as we've sort of spoken around before, some disease-modifying therapies are safe to use in pregnancy and should be considered in women with highly active MS, and alternatively planned pre-pregnancy use of disease-modifying therapies with long-lasting effects might provide effective disease control during pregnancy whilst minimising drug exposure during this period. And I've put a really big asterisk there as well, because again, this is something that everybody should discuss with their neurologist in terms of thinking about things such as how well controlled their MS is. Your doctor knows your MS the best. So they're the best person. Well, you know your MS the best, but after them, your neurologist knows it the best. So they're the best person to talk to about these things. But again, looking at these different disease modifying therapies and the categories and what that means. And so, you know, speaking to these long-lasting or disease-modifying therapies with long-lasting effects, which ones are we referring to here? There's really 3 of them here. I'm not that alemtuzumab or Lemtrada is available in New Zealand, but I believe that cladribine, also known as Mavenclad, again, not sure about that one. Ocrelizumab is, that's Ocrevus. And so in each of these, you can see that there are bits of advice here as to how soon after you have an infusion or a tablet for these medications you should wait before you try to conceive. And so because all of these medications do have quite a long-lasting effect after dosing, it is potentially safe to try to conceive after, say, 4 months after a last alemtuzumab dose, 6 months after a cladribine tablet dosing schedule is completed. And with ocrelizumab, the package advice and the advice from the manufacturers is 12 months, but again, really big asterisks there because new research that's being done at the moment suggests that maybe that could be shortened, and I'll speak to that a bit later as well. So looking at relapse in pregnancy. So, you know, I showed you that historical data before that overall relapse rates do decrease during pregnancy, and they're the lowest in the 3rd trimester. But again, this is work from Wei Yi, one of my amazing PhD students. And he was looking at the use of disease-modifying therapies in pregnancy and what impact that has on relapse activity. And so this here is a graph where he's basically divided relapse activity in pregnancy and postpartum based on which medication women were taking at the time. So the sort of the line graph means that women weren't on any medication. The pink bar here is, or the pink line refers to women on injectable therapies. DMF is dimethyl fumarate, also known as Tecfidera. FIN stands for fingolimod or Gilenya, and NAT is natalizumab or Tysabri. And so these are just the different relapse patterns on these different drugs. Now, the big caveat here is that fingolimod has now been shown to have an increased risk of fetal malformations. And so whilst we collected this data, it's really important to note that this is no longer considered to be safe to use in pregnancy. And so, you know, it's based on historical data. Okay, so looking at his data, what we found was that there were differences in relapse rates during pregnancy, depending on which disease-modifying therapy people were or weren't on. So when we looked at women on low efficacy, no efficacy, or Tecfidera, we found that relapse rates decreased and were lowest in the 3rd trimester. But this was a slightly different story with other medications. Now, I won't go into fingolimod because, as I said, that's no longer indicated for MS. But with natalizumab or Tysabri, what we actually found was that there was, if anything, maybe a slight increase in the relapse rate during pregnancy. But there's a really big caveat around that, because when we looked at this, there was a range of times when women discontinued the use of natalizumab. What data has showed us so far is that natalizumab does not cross the placenta in the 1st trimester, but it may start to cross the placenta in the 3rd trimester. So it seems to be safe to use Tysabri up until the 34th week of pregnancy, but it should not be used after the 34th week. And whilst using it in pregnancy, it is safe to extend the dosing schedule to be, say, every 6 weeks instead of every 4 weeks. The reason why we see this increase in relapses here, though, is because that's related to women who discontinued using natalizumab or Tysabri. And so it's one of these things that's kind of been known in the literature that when you discontinue a disease-modifying therapy, your disease activity can re-emerge. And so that's basically what this is showing us, that as women discontinued using Tysabri through their pregnancies, there's a sort of a delay. So there might be, say, a 3-month delay in terms of the drug is effective for a period of time, but once it's completely washed out of your system, it may mean that you have disease reactivity reoccurring. And what this basically tells us is that women who have highly active MS, who are prone to relapsing, if you withdraw certain drugs from them, they may end up having a relapse in pregnancy regardless. And so it's another consideration to take into account with your neurologist when you're deciding if you are going to continue a particular medication, and if you are going to continue it, how long are you going to continue it for, how long is it safe to continue it for, and when should you withdraw it, and if you do, what does that mean in terms of disease activity re-emerging. But in terms of the predictors of what were the things that were likely to predict whether or not a woman was going to have a relapse in pregnancy, we had a look at this again in the study. And what we know in general with MS is that relapses just decrease or diminish over time with age. That's just sort of the natural history of what MS does. Relapses just decrease over time. And so the older a woman was in pregnancy, the less likely she was to have a relapse. And then, as I said, the disease-modifying therapies that they used. So continuation of some disease-modifying therapies into pregnancy could reduce the risk of having a relapse. So, for example, those women that continued natalizumab up to the 3rd trimester, we didn't see any relapses in them in pregnancy. But if these highly or moderately effective disease-modifying therapies were stopped, then the chances of having a relapse in pregnancy did increase. And again, as I've sort of spoken to already, relapse activity sort of begets relapse activity. So if you already have active disease, you're more likely to continue to have active disease in pregnancy regardless. A little bit about MS and DMTs in pregnancy. So I think, you know, a lot of the advice and a lot of the information that we have at the moment with respect to the use of these disease-modifying therapies in pregnancy comes from registry studies. And that's mostly because, you know, women are excluded from participating in clinical trials. There's the whole ethics of exposing a pregnant woman and her fetus to an experimental drug. And it's kind of tricky because women, when they're thinking about pregnancies, really feel like they're torn between these two choices. They have the choice of themselves, so to continue to take their disease-modifying therapy in order to control their MS, or they have the choice of their child and stop taking their disease-modifying therapy, potentially have a re-emergence of disease activity, but protect the child from potential drug effects. And so really, you know, there is a whole lot of lack of data. And so the sort of the work that we do using registry data, where we observe women who have become pregnant when they're taking a drug, not in the context of a clinical trial, but just in the context of real life, and trying to provide information and try to get a handle on what's going on that way. So as I said, a lot of our data is from registries and the sort of work that we're doing, and the new registry that we've developed with MSBase. And so again, just sort of recentering ourselves on these drugs and the disease-modifying therapy classes. So what we can also tell you about the use of disease-modifying therapies in pregnancy. So again, this is from my team and from Ailan and her PhD. We had a look at, again, the MSBase data set, and we had a look to see the trends of, you know, how many women are becoming pregnant on disease-modifying therapies over time. And so again, a slightly different data set, slightly older one now, published back in 2019. But here we identified just over 1,500 pregnancies. And we had a look to see, of those pregnancies, how many women were not exposed whatsoever to a disease-modifying therapy in the year prior to their pregnancy, how many discontinued it within the 12 months prior to conception, and how many continued taking a disease-modifying therapy. And so what this bar graph here shows us is, in orange, the increasing trend for women to stay on disease-modifying therapies until they got pregnant. And I think ours capped out at about 62%. And when we compare that against registries from other places like Germany and from Brazil. So slight mind blank. It's really consistent. So globally, we're seeing these same trends that doctors are feeling more and more comfortable leaving their patients on disease-modifying therapies, at least until conception. And in our particular study, it seemed to be exactly that. So the average exposure during pregnancy in this study was about 30 days. So probably about the time when you might be thinking that you might actually be pregnant and doing a pregnancy test and discovering that you are. Again, in this particular study, we looked at the number of pregnancies that were considered to be term, so 37 weeks and above, preterm, the number of pregnancies that were reported to be a miscarriage or an induced abortion. And we then broke that down based on those that were not on disease-modifying therapy or those that were on disease-modifying therapy at the time. And again, we found that typically speaking, the numbers of induced abortions and miscarriages were very much within the normal range of what we would expect for all of the different or I should say normal of what we'd expect in terms of, miscarriages are just unfortunately reasonably common. And we didn't see an increased signal of miscarriages on any of the disease-modifying therapies that we looked at. Okay, and so this is a little summary that I put together in terms of some of the most commonly used disease-modifying therapies and whether or not they seem to be safe to use in pregnancy or not. So I said previously that interferon betas are a pregnancy class D, meaning that, they may be associated with malformations, but this was really because these were the first medications that became available for MS. And at the time, there really was no data when the drug companies registered these interferons for use in pregnancy. They had no idea. So they just said, well, we don't know. So we're going to classify them as a level D in order to protect the fetus. But since then, a lot of women have become pregnant on these various disease-modifying therapies. And so we now actually do have quite a bit of evidence that shows that there is actually no increased rate of malformation or abortions on interferons. And so actually, I believe that the various drug companies are hoping to change the pregnancy category rating from a D to a B. That hasn't happened yet, but that's something that is in the works as far as I'm aware. Again, Copaxone has been shown to be safe to use in pregnancy, and Tecfidera is another one that's been shown to be okay, at least to conceive on. And the EMA, so the European Medicines Agency, also says that it's okay to continue using it if the benefits of the drug outweigh the risks. So in other words, if a woman's got highly active MS, it's probably okay to stay on it. As I said, Tysabri is the other one that doctors are comfortable keeping their patients on, but it must stop being used in the 3rd trimester. Now we have these other 4 medications here that have been said are not safe to use in pregnancy. So the first one is Ocrevus. And as I said, the package says that it should have a 12-month washout, although the latest advice is that attempted conception can start to occur about 1 to 3 months after the last dose has been taken. And that's because of the amount of time that it takes for the drug to wash out of the system. And it's, again, much like Tysabri, it's believed that it doesn't cross the placenta in the 1st trimester. So it seems to be okay to try to conceive sooner than what was originally said. But again, it's a conversation that needs to happen with a neurologist. Okay, and so then there are these oral medications, and none of the oral medications have been considered to be safe to use in pregnancy. That's because they can cross the placenta. And so there are different washout periods that need to be considered. But I guess the one thing with Mavenclad is after that 6-month washout, because it does give such a long level of protection against disease activity, 6 months later, it's probably fine to try conceiving, but just don't take it whilst you're pregnant. In terms of neonatal outcomes, there was this neat study, that came from a colleague of mine in the US from Riley Bove's group. And they looked prospectively at women who had become pregnant on various disease-modifying therapies in the US. And again, they found that the use of assisted reproductive technology was quite common, so about 29%. 47% of pregnancies in their study were exposed to disease-modifying therapies. Average time to conception was 7 months. And what they did in this study was they actually looked at other things. So they actually looked at baby weight, baby length, and head circumference in this study as well, just to see whether or not there were any differences compared to the World Health Organization reference standards for other American children. And interestingly and reassuringly, they found that irrespective of drug exposure or not, in women with MS, the average weight and length of babies was well within the average range of the WHO references. But again, interestingly, they reported that there was a possible increase in the head circumference of some of the babies born to women with MS. However, this didn't seem to be associated with any long-term or longer-term disabilities or differences in terms of child development or anything like that. So overall, again, I think a very reassuring study that's just come out recently. The last couple of points just in terms of pregnancy was that if you do end up having a relapse during pregnancy, corticosteroids can be used for their treatment. Again, needs to be done in consultation with a neurologist. And again, if there isn't a reason why you need an MRI, again, this isn't what we say contraindicated. So it means, in other words, like an MRI can be done when you're pregnant, so long as you don't have any contrasting agents used, it should be totally fine and safe. Okay, I feel like I've been rabbiting on for ages. So again, I'm going to stop sharing in case there are any questions.
Do we have any questions that anyone would like to ask now? We've got one here. The WHO refers values are adjusted. Are the babies born to mothers born at term or preterm?
That is a very good question. I am going to assume that they have the reference values for all of the above. I haven't had a chance to look into it in a lot of detail. So in other words, if they were preterm, they would have been referenced against preterm. If they were term, they would have been referenced against term.
So do women with MS deliver mainly at term?
Typically speaking, that's what we've seen. There doesn't seem to be any noticeable difference in terms of whether or not women have MS and whether or not they deliver at term or not, or preterm. So it seems to be very consistent just with the general population. There's no indication that there should be preterm births as a consequence of MS. Just some women deliver preterm just because that's just what happens. It's not MS related.
Yeah. Have we got any other questions at the moment? Oh, are there any studies based on ethnic women with MS and pregnancies, such as Indian or Asian?
Again, there is a little bit being done. So Ruth Dobson in the UK is doing a bit of that at the moment. There's not a lot published. At the moment, typically speaking, most of the studies have sort of consolidated all ethnicities into their studies and not sort of subdivided specifically into Indian or Asian. But everything that I've read so far, when standards are done, they are done against the appropriate sort of ethnic group as well. And so that's certainly what we're doing as well at the moment with our research, so that now, whilst we are accumulating more pregnancy information, we are actually asking for ethnicity as well, so that we can do any adjustments or measurements against ethnic group averages, because we know that obviously some ethnicities throw bigger babies, some throw smaller babies, and so we're trying to make sure that we account for that in our research as well. But yeah, look out for Ruth Dobson's work in the future.
Breastfeeding and medication for MS. Is it safe to start back on medication, and do the same rules apply? Oh, sorry, do the same rules apply as pregnancy?
I will get onto that in my next bit coming up like now.
There we go.
If you don't mind waiting.
Great, let's carry on.
Okay, so that's exactly what I was going to look at now, which is looking postpartum. So I know that I'm running out of time a little bit, so I'm just going to say that postpartum physio is a good option, irrespective of whether or not you have MS, but I think particularly in the context of MS. And there is a higher risk of having a postpartum relapse rebound, as we've sort of spoken about already. Again, looking at Wei's work and looking at this period here. So in our study, again, so here looking at 1,640 term pregnancies, we found that about 13.6% of women had a relapse in the first 3 months postpartum. And so trying to understand, one of the things that I wanted to say actually, before I moved on, was that, you know, typically speaking, it's been sort of assumed that women who are not on any MS therapies will probably fare better than those that are on MS therapies. You can see this massive spike in relapse rebounds for those women that were on highly effective or moderately effective therapies, and that the relapse rate for women not on therapy is a lot lower. But when you compare it to the pre-pregnancy rate down here, you can actually see that it is appreciably higher. So I think that it's really important not to be complacent if you have a pregnancy that is not exposed to a disease-modifying therapy, and that you should still be aware that it is possible that you could have a postpartum relapse rebound. Now, whilst we've reported within our studies these postpartum relapse rebounds, there is one study that was published in the US that reported that there is no such phenomenon anymore. And so this was a study from California. And I guess the difference between our study and their study is that their study is more community-based. So in our research, we typically don't see women who have incredibly mild MS and who are managed, say, by GPs or general neurologists or private neurologists. Whereas in this study, they saw the whole range, and this also included women with clinically isolated syndromes. And so if you look at the relapse rates in the 2 years prior to pregnancy and in the postpartum period, you can see that those relapse rates are more or less the same. They're quite aligned. And so the argument was made that the relapse rebound phenomenon doesn't exist anymore. My one caveat here is that the baseline relapse rates are actually quite high in this study, pre-pregnancy relative to ours, where for us, at least in women who have quite mild MS, it's maybe about 0.2. As about to a 0.4. So what a 0.2 annualized relapse rate means is that on average, somebody has a relapse once every 5 years, as opposed to 0.4, which would be once every 2.5 years. So the jury's out a little bit on this. I think one of the things that is potentially, again, quite understudied is the impact of abortions and miscarriages and stillbirths, and whether or not women who have these experiences have postpartum relapse as well. And so this is, again, something that we looked at in our paper. And we found that almost 10% of women with abortions or miscarriages also had a postpartum relapse. And so I guess previously it was thought that, you know, it's because you have this massive shift in hormones after the 3rd trimester that's possibly what's causing the relapse rebound. But it looks like even early pregnancy changes can still mean that there is this relapse after a terminated pregnancy. And so again, something to look out for, and something that we're doing more research on as well. And this is another study by another group, also published relatively recently, where they suggested that women that had elective terminations as opposed to spontaneous miscarriages were maybe at slightly increased risk of having, again, a post-abortion or post-termination relapse. So just something to be aware of. Okay, so looking at reinitiation of disease-modifying therapies, and again, looking at this data, so some of the things that we found that could be protective against having a postpartum relapse was reinitiating a disease-modifying therapy very soon after giving birth. And we actually found that restarting really highly active or highly effective, I should say, therapy, such as Tysabri, Ocrevus, Lemtrada, was able to reduce the risk of having a postpartum relapse by over 80%. But even restarting a lower efficacy drug, so one of the injectable therapies, was also able to reduce the risk of having a relapse by about 60%. Again, really important to have that conversation with your doctor. With the oral therapies, our study didn't have that many oral therapies in there because there's just not that many women taking them yet because they're relatively new medications. But again, there was reasonable evidence to suggest that these may also help reduce the risk of a postpartum relapse. And then another thing is that women should be aware that there's some evidence that breastfeeding may be beneficial in terms of preventing a postpartum relapse. And so the jury's still a little bit out on this one. This was a study that looked at a number of different studies again that reported whether or not there was benefit or net neutral effect of breastfeeding. And typically speaking, that's exactly what they found, net neutral or protective. In our study, again, we found that exclusive breastfeeding was protective against having a postpartum relapse by about 40%. And so what I mean by exclusive breastfeeding is exactly that, just breast milk and any vitamins or medications if a child needs them. So no mixed formula feeding. There's less evidence to suggest that that is as effective. But as to the question that was just preempted previously, we also need to have considerations about disease-modifying therapy use whilst breastfeeding. And so this is my summary here. And so hopefully this answers the question for the person that asked it. And so a lot of this evidence comes from women donating their breast milk if they have restarted a therapy after giving birth, and that breast milk being analysed to see whether or not any of the medication crosses into the milk. And so this is what I have here first in the top row here, just looking at studies that have analysed whether or not these drugs can get into the milk. And where I've got question marks, that just basically means we just don't know. Those studies haven't been done. We don't have any data on it. And so where we do have ticks, we do know there are studies that have shown where the milk has been analysed that you can find trace amounts of these drugs in the milk. And so those include interferon betas, Tysabri, Ocrevus, as well as Mavenclad. But when they analyse the amount of drug that gets into the milk, they also look at sort of a relative dose of how much of that has actually gotten through and whether or not that dose that's detected could potentially harm the baby. And so here where we've got the ticks, and this bottom row, which says safe to use, yes or no, it's because the amount of the medication that gets into the breast milk is so low that it's been considered to be safe. And in fact, in the studies looking at Tysabri and Ocrevus, what they've actually done is they've taken blood samples from babies just to see whether or not, again, the drug is detectable in the blood sample of the baby, and also just analysing the constituents of the blood of those babies. So we know, for example, that Ocrevus knocks out your B cells. And so in the studies where they've looked at Ocrevus and rituximab, which is quite similar to Ocrevus, they've actually found no decrease in the number of B cells of the babies that have been exposed to breast milk of mothers taking those drugs. So it's been shown to be safe to use. Again, with the oral medications, so Aubagio, Tecfidera, Gilenya, and Mavenclad, because these are small molecules, they're more likely to get into the breast milk. In fact, a very, very, very recent study just showed that Mavenclad does, and these are not considered to be safe. So again, another consideration and another conversation to have with your neurologist. But there are certainly medications that are safe to use or seem to be safe to use. But again, a lot more research still needs to be done. Okay. So the final point here was just that you should know that, you know, having a baby is fatiguing. You probably know that already. It's tiring, you know, late nights and sort of really mucked up schedules and all the rest of it. And so fatigue is super common in everybody, let alone, you know, having MS. And so we also advise that you should, if you are breastfeeding, to pump milk and to store it so that if you're too tired, your partner can potentially feed the baby. And if you do end up needing to have steroids, there's just a bit of a gap between receiving a dose of steroids and being able to breastfeed. I think the other thing that I've probably not really articulated, but I should as well, is, you know, talking about breastfeeding and the benefits of that potential, well, definitely, you know, for the baby, as I say, and potentially for the mother in relapse, is, you know, the other thing that I certainly do stand by is that if you can't breastfeed, you should never feel guilty about it. You shouldn't feel pressured into it. And again, the benefits of breastfeeding in terms of relapse as well, whilst they do seem to be there, they are modest as well. And the benefits of restarting a disease-modifying therapy are still greater. So again, I think it all just comes down to individual differences and doing what's right for you and right for your baby. So I don't want to sound like I'm pushing it, because I'm certainly not. But that was really the last little bit of what I wanted to cover here before I do a quick little spruik about research. But anyway.
We've just had a couple of questions come through. So first question is, I noticed that you're saying restarting DMTs. What if you switch your DMT from before pregnancy to something different after therapy?
That's totally fine. So when I say restarting, I just basically mean starting. It doesn't have to be the same drug. And it's actually quite common to switch drugs thereafter as well. We've seen that quite a lot in our different studies. So don't be afraid to switch it up if that's the right thing for you.
The postpartum graph for relapses for the different medications. If I stopped fingolimod at the recommended time before becoming pregnant, do I count as a fingolimod person on the graph, or someone who was on nothing? E.g., is the graph only for use of medication during pregnancy, or does it matter if you had just finished a treatment? Yeah, so with that, we were looking at exposures into pregnancy and discontinuing during pregnancy. If you discontinue beforehand, it really depends on the duration. So again, there's this phenomenon of relapse rebound with fingolimod. And so if you do discontinue that in order to become pregnant, the first thing is, you know, what's the gap in terms of how long you wait? And also your neurologist might decide to put you on another treatment sort of as a bridging therapy in between as well. So no, you shouldn't, if you've stopped fingolimod in order to become pregnant, you shouldn't necessarily consider yourself to be on that graph. Great. And if you, how can you say it is safe to use if there is no data on milk transfer with use of Copaxone? That's because whilst they haven't actually measured the amount of Copaxone going into the breast milk, this is based on studies where they have, so nobody's donated the breast milk to analyse it, but studies have been done on infants fed by mothers on Copaxone. And then studies have been done looking at growth charts, development, neonatal development. And so that's what's been reported in the literature. So whilst they haven't measured it directly in the milk, they've looked at child outcomes. Great. And so we will slightly go over time, everyone. I hope that's okay. But it's still obviously really, really interesting and important information. So if you want to go back to your slides. Sure, this is super duper quick. That one there. Okay. So I guess it was just really a few take-home messages from the end of the talk. I think it's always good to sort of centre back on what we've spoken about. So basically, I just wanted to reiterate that MS does not affect fertility in any sort of significant way that we've been able to see, although we are still continuing to do research on that point. That if you are planning pregnancy, that you should start early, and that should be for both men and women, because again, some of the medications that men are on, they shouldn't father children whilst they're on them. Again, Obagio being one of them, and cladribine being the other one with needing, Mavenclad being the other one with needing to have a bit of a break in between. Women should just follow standard obstetric advice. They should know that pregnancy is not going to be harmful for their MS disease course. That relapse rates may reduce for women when they're pregnant.
but it is still a time of disease activity for some women, so it's still important to be vigilant. Exclusive breastfeeding may reduce the risk of postpartum relapse. And again, there's still a lot that we don't know and a lot of research that is ongoing in this space. So how can you participate in research if you want to? You know, there's a lot of people that you can ask about it, ask your neurologist, check with MS societies, different universities also sometimes advertise research. And there's also lots of different types of research that you can be involved in. So there's the typical clinical trials of new drugs, but there are also a lot of other different types of studies. So investigator-initiated trials, which is a lot of the sort of work that we do or that I lead as well. So that's, you know, where we have a question. So for example, looking at pregnancy and impacts on long-term outcomes, or the use of disease-modifying therapies in pregnancy if you happen to have become pregnant outside of the context of a clinical trial. And as I said, registry studies are one really great way to get involved. And so, as I said, a lot of the data that I've presented to you today is from MSBase. And I believe that some neurologists in New Zealand are participating in that. Hopefully you've seen that the data that we present is anonymous, so we don't know actually who you are when we're analysing the data. We just know that, you know, it's a person with MS who's very generously allowed us to analyse their data so that we can get better evidence to inform everybody to try to manage everybody safely and give them the best medical advice. So, you know, if you're ever asked to participate, do certainly consider it, because we know that it sort of helps everybody with MS. And so I think finally, just the last thing to do is to really acknowledge my team. This is always a massive team effort. And so this is my team. And so some of the research that I've shown you today was done by Wei, who is a consultant neurologist and superstar PhD student. Elan, who's another consultant neurologist who just finished her PhD with me. Yui over here, who is a medical student, who is my honours student, and Pia Campagna, who I haven't presented any of her work, but she's a superstar scientist working with me, and she's actually going to be looking at the biology that maybe explains some of the things that we see with respect to pregnancy, and the rest of my team. Really importantly though, I do want to acknowledge all of the women with MS that have also answered our surveys and really generously shared their very often private pregnancy stories with us, you know, particularly hard when they speak to things about miscarriage and termination and that sort of thing. So we very much appreciate that. And again, nothing's ever done in a vacuum. So I'm super lucky. I'm a scientist, but I work with incredible doctors and nurses. And so I just want to thank our leaders within my unit at Alfred Health, so Annika van der Walt and Helmut Butskuven, who are absolute superstars, as well as Olga Skabina, who's another passionate neurologist. Our nursing team are absolutely incredible, and in particular Louise Rath, Nicola McGuinn and Naomi Loftus have been incredible in this effort. And then all of the other doctors and nurses listed here, and a whole stack of other collaborators without whom this work would not be possible. So
I've got one last question that's come through, that's okay. Is there a recommended time to go back on a medication before coming off again to try for another baby? E.g., is it worse to go on for a very short time if I know I want another baby?
So again, I think it's a really important discussion to have with your neurologist. I think it depends on how stable your MS is, whether or not you've had relapses, what your MRI scans look like and that sort of thing, and which medication it is that you're going on, and whether or not that's a medication that's safe to conceive on. So I think that there's a lot of considerations, but I don't think that you shouldn't. But I think, you know, as I said, a really important conversation to talk to your doctor about.
Great. Thank you so much, everyone. And thank you so much, everyone, for joining us.